Okay, let's continue. So if you see a woman and you do these labs, she will have HELLP syndrome, which is an obstetrical emergency. HELLP syndrome can lead to cerebral hemorrhage, retinal detachment, liver rupture, acute renal failure, DIC, placental abruption, and maternal death. So that's why this is such a big deal. So with preeclampsia, the treatment is, or the treatment aims to lower blood pressure and to prevent seizures. So we can give a number of antihypertensive meds: hydrazoline hydrochloride, labetalol hydrochloride, nifedipine, sodium nitroprusside. But what we do give, it's the drug of choice. And interestingly enough, all of the drugs that a lot of the times the drugs we use in pregnant women, they're used for other things, and we use them as off-label use. They're not approved from the FDA to use them the way that we use them, but we do use them this way. So it's just kind of interesting. So magnesium sulfate is a central nervous system depressor, and it's an anti-seizure medic because it causes smooth muscle relaxation. So, but there are side effects, and we're going to look for these side effects when we are treating a woman with magnesium sulfate. We're going to monitor very closely, and the baby is going to be a floppy baby, because anything that goes to the mom, remember this is a central nervous system depressor, it's going to be, depress the central nervous system of the baby as well. But if it prevents seizures and that permanent brain damage and death, then that is it's that risk versus benefit that we're always trying to weigh. So when a woman does experience eclampsia, that's the onset of seizure activity, and she can go into a coma. And it's preceded by a headache, that severe upper right epigastric pain with the liver hyperreflexia, and the hemoconcentration, because all the problems with the HELLP syndrome. So let's talk about what we do when we give magnesium sulfate, because it is something we have to monitor very closely. And just like meds that you need to have it stopped immediately, we're going to piggyback it onto a secondary infusion pump. Why do we piggyback into secondary infusion pumps instead of that main line? Because we know when we stop the infusion, it stops. And with magnesium sulfate, because it can cause respiratory depression, we need it to be stopped immediately in that case. So we give an initial loading dose, and then we do a maintenance dose. And those will just be the orders that you'll receive from your doctors. But this is kind of classic loading dose and maintenance dose. So the client will feel flushed, hot, and sedated. Those are normal signs of, or normal things that happen when we're giving magnesium sulfate. So how we're going to monitor our patients: we're going to monitor our pulse, blood pressure, and respiration, so vital signs, every 15 to 30 minutes. So very, very closely. We're in the room with that patient. We are going to continuously have them on monitors. So the Doppler transducer monitoring fetal heart rate, and the TOCO monitoring the contraction pattern, because we're trying to see if the fetus is doing okay. Why do we always do contraction pattern with fetal heart rate? Because we want to see if they're experiencing late decels, and we can only see if the decels are early or late if we're looking at the contraction pattern alongside the fetal heart rate. So we're going to look at the neurological status of that mom, and we are going to monitor the patellar reflexes every hour. We're going to look for oliguria, or intake and output. Output should be greater than 30 mLs per hour, and they should have a restricted fluid diet. Remember, because they have leaky blood vessels, so everything we're giving them is going to cause massive edema, pitting edema. So we have to restrict their fluid, but still make sure that they're getting enough, their kidneys are being perfused enough, by watching their output. We're going to assess for the headache, visual disturbances, loss of consciousness, and epigastric pain. So if you see any of these things, that means that she's worsening. And remember, these are what's going to happen before the onset of seizure activity. And because magnesium sulfate is a central nervous system depressor, we need to dim the lights, keep those side rails up because she's a high risk of falls, and keep her environment quiet. Okay, so other things to think about with magnesium sulfate. It can be toxic. And how we know, how we're assessing for toxicity is we're looking for lethargy, muscle weakness, decreased. Those reflexes are going to be absent at this point because we have completely taken away those hyperreflexia, right? She has decreased urine output, decreased respirations, which is the #1 emergency. She can code if we are not careful, and then double vision and slurred speech. You see any of these happening, then she's toxic and she's getting too much. So with toxicity, we're going to stop that infusion immediately and give the antagonist, which is calcium gluconate. And then we'll prepare by getting the crash cart for respiratory or cardiac arrest. Hopefully it doesn't, get to that point. Okay, the next things we're going to talk about, we're going to finish off with the early onset of labor, which is chapter 10. So there are different things we're going to watch for that can cause problems before a woman goes into labor. And so the first one here, let me kind of lift this up if I can. I can't. Is preterm labor. So this is uterine contractions before 37 weeks, right? Between the age of viability here and 37 weeks. That is defined as preterm labor. And how we diagnose preterm labor is we're going to check for these fetal fibronectin. And we're going to do it with a vaginal swab. And if we see those, we know it's related to inflammation of the placenta. And when there's inflammation of the placenta, so if we're looking right here, we're kind of blowing this up. You see the fetal membranes here, that's the amniotic sac, and the maternal membranes here, so that is the uterus. And in between there are this fetal fibronectin. If you see this coming into the vaginal secretions, then she's at risk for preterm labor. And so that's a way we can check to see if she is going into preterm labor, or if she will go into preterm labor. So the treatment for preterm labor is to stop those uterine contractions. How do we do that? We can offer, teaching by telling her to have activity restriction. So modify the environment, modified bed rest. So not complete bed rest because that can cause problems as well, but left lateral position that increases blood flow to the uterus and it will decrease uterine activity. And then we're going to have her avoid sexual intercourse because we know that sexual intercourse can release oxytocin, the bonding hormone, right? So we want to have her avoid sexual intercourse. Also, we're going to have her, for the same reason to avoid sexual intercourse, is we're going to make sure she stays hydrated. Dehydration, I think I've told you this in earlier lectures, that it stimulates the release of oxytocin. So that's why women need to stay hydrated at all times if they do not want to go into labor. And then we're going to identify and treat infections. She could have inflammation because she has some sort of infection going on. So we're going to look for that tachycardia, elevated temperature, and look to see if we see fetal tachycardia. If we see fetal tachycardia, then we know that there's chorioamnitis, which is an infection of the amniotic fluid, and the infant is infected as well. And we can also, if there is rupture of membranes, we can look at that amniotic fluid to see if it's cloudy, green, or foul smelling to see if there's any problems. So the medications that we use to stop preterm labor are tocolytics. These are just smooth muscle relaxers. We can use nifedipine, indomethacin, magnesium sulfate. So that is what you see in your ATI book. On the units, we use terbutaline. So I don't think you need to know about terbutaline or to differentiate between all these. Just know that these all do the same thing. They do it in different ways. One is a calcium channel blocker, another is a beta antagonists, which is what terbutaline is, but you just need to know that it's a group of meds, and they're called tocolytics, and they are smooth muscle relaxers. And you'll see that magnesium sulfate here is a smooth muscle relaxer, but it's not our first line that we use. Terbutaline is what we use when we see a woman in preterm labor on the unit in real clinical practice to stop those contractions so that we can preserve the pregnancy. So now the goal of delaying the preterm labor is a lot of times just to delay up to 48 hours, like you see here, because we want to be able to give those corticosteroids to help fetus facilitate lung development, so to help them produce surfactant. So that means we need to give a mixture of tocolytics with betamethasone, and that is the goal with medication therapy in preterm labor. We're trying to preserve it as much as we can, but really that 48 hours is critical. So we give betamethasone. It's a glucocorticoid. It's an IM gluteal muscle shot. So we give it to the mom, and we give it 2 different shots. That is the evidence-based practice best practices. So we give one at 40. So we give one, and then we have to wait 24 hours for that to have its full effect. And then we're going to give another one and then wait 24 more hours. So if we can give those 2, we know that that will have the best outcome for that fetus, and they will have lower respiratory or oxygen needs. So we give these to babies between 24 to 34. Why 24? Because that is really the lowest age that they will resuscitate babies. Like I said, sometimes 23-weekers are safe, but it's really 24-week is the real line that we try to draw. And then 34-weekers, anything after that, we're hoping that there is sufficient surfactant production that the baby will not need to be intubated or will have lower resuscitation needs. Okay, so the last thing we're going to talk about is that rupture of membranes. So there's 2 different kinds. It's just this water breaking before the onset of labor. So even though the amniotic sac has ruptured and she's leaking fluid, that doesn't mean that she's going into labor. What is labor? It's these true contractions that act on the cervix to, efface and dilate that cervix, really open that cervix up to allow the baby to come out. So when you see prom or pre-prom, it does not mean that she's going to go into labor. It just means that the amniotic sac has ruptured. So to define these, prom is that rupture membranes before the onset of true labor. So a woman can have ruptured membranes and not be contracting regularly or not have these true contractions. And she will not go into labor unless we stimulate her too. So we like her not to go over 24 hours of having ruptured membranes. Anything after 24 hours puts her at a very high risk for chorioamnitis. In fact, if we know she has had a ruptured membranes greater than 24 hours, her baby will automatically go to the NICU for a prophylactic antibiotic for 5 to 7 days. Usually it's a 7-day course. And then with pre-prom, that's preterm premature rupture of membranes. And that's the rupture membranes before 37 weeks. So like I said, that high risk of bacterial infection of the amniotic cavity, and you'll see it with these same kind of clinical manifestations. And we treat the mom with clindamycin usually, or we can use metronidazole, and the baby gets Ampingent when they go to the NICU. And so we can give client education because just because they are ruptured doesn't mean they necessarily have to come in. So they can go home if less than 3 centimeters dilated, and we're going to teach them to do those daily kick counts to make sure that their baby's okay at bed rest and keep nothing in the vagina. So no bubble baths, white front to back, no intercourse, anything like that. If it occurs before 30 weeks, we're going to try to prolong that pregnancy. If not, we're going to just let her go into labor, or if there's any sort of problems that can lead to a reassuring fetal status. This gives time for that betamethasone to kick in, right? Remember? And leads to fewer neonatal complications. So it's better outcomes for the fetus. And that is the end of antepartum complications. And I will just start writing tomorrow on the labor and delivery. I'm trying to get these out as soon as I can to you, so I will be in touch.